Dear friends, today we're going to talk about a very important topic, preparing for surgery from tests to many other things. This isn't only about scheduled surgery. Sometimes it's about emergency surgery, even if none is planned for tomorrow. Well, an appendectomy and many other surgeries can happen to anyone, or to your grandmother, grandfather, you never know. This information is useful to share because it will directly affect how well the surgery goes, how quickly you recover afterward, and how low the complication rate will be. Today's No Fluff, Only Facts episode features a practicing surgeon. Watch until the end and share with a friend. I often get calls on my phone where they say, "We have a patient coming in with these test results. Should we admit them or not?" There are already many problems during hospitalization. Even after explaining everything, people still arrive unprepared. The first rule is that test results have an expiration date. Some tests are valid for 10 days, some for 14 days, and some for a month. Now, for example, the rules for human immunodeficiency virus hepatitis and syphilis tests have changed. Previously, these tests could be valid for several months, but now they have to be recent. Maxim's test must be less than a month old. Blood type also doesn't change during a person's life. Each medical record during hospitalization needs its own form, which is why there are various passport stamps and test expiration dates. Because it's limited, many people take them 1, 2, or 3 days before, so they won't be expired. Actually, very often when you take tests, you don't look, you don't understand what's there. And of course, it's better as soon as you're scheduled for surgery to take the tests right away and check what's there. It's important to not only take them, but also identify what's wrong. And very often they come in, and on the day of hospitalization, they call and say, "Here, the hemoglobin is abnormal, the globin is low, Ziki, and here something's missing, and here it's on fire, Niski." Rule number 2 is to remember that beyond the tests, it's not just a formality. And always check the protein level, always check the hemoglobin level, always check the file level, and quietly check the iron level. Why is this important? Because it directly affects, for example, how quickly a wound will heal if you have a low protein level, if you have a low one. Gelet for fritena. Healing is slower because oxygen is transported less effectively in the body. And if a person loses blood during surgery, this can happen in any operation. This problem will get even worse for you. That's why an operation that could have taken 4 or 5 days, admission, surgery, and discharge in 3 or 4 days, you spend 10 more days in the hospital as your wound doesn't heal, and the surgeon now only changes your dressings. The wound didn't heal, it just simply didn't close up. It's essential to check sex hormones, but no one pays attention to that either. I think if you're going in for some major complex reconstructive surgery, you definitely need to check your sex hormones, for example, if it's a serious reconstructive operation on your leg. And if you need to have your knee joint replaced, or for example, if you have cancer and they're removing your bladder and making a new one. That is, anything that takes a long time and involves a large amount of surgical intervention. It's very important for sex hormones to be at normal levels, because continuing, if, for example, your sex hormone levels are low, then the synthesis of new tissues is also low. In other words, anabolic processes are slowed down. Going into surgery with very low testosterone isn't ideal, and it's not always about hormone replacement therapy. The same applies to clomiphene. You can boost testosterone even as you age. If you prefer not to use hormone replacement therapy, you can still increase your testosterone 2 to 3 times in 2 to 4 weeks. If you have hypogonadism, and believe me, the healing processes will go much better. Thyroid hormones affect metabolism. You definitely need to check if everything is okay, if there is no hypothyroidism or thyrotoxicosis. Why? Because it affects not only how everything heals, but also many metabolic processes. And it's also very important not to miss this during anesthesia, because all the drugs you administer can affect you differently. Be sure to check the C-reactive protein. That's a C-reactive protein and homocysteine. C-reactive protein will show inflammation in the body. If you have severe inflammation, everything in your body will heal worse. Sometimes surgery isn't possible due to severe inflammation, because often there aren't any symptoms like a runny nose or a cough, but there still can be inflammation. Homocysteine, we definitely check it. Homocysteine, do you know what homocysteine is? Well, roughly speaking, that's what greatly increases the risk of cardiovascular disease. And at the moment, we're used to thinking that my homocysteine is high because I'm lacking B vitamins. It's something that will come back to haunt you someday, but in reality it also affects the risk of acute conditions. That's why a B vitamin deficiency must be corrected. All deficiencies like vitamin D deficiency also need to be addressed. That's why the test results should be recent. But it's not just a pass to the table. You definitely need to take them yourself, study them, and look them over. If you see yourself that something is not normal, then think about why. And while you still have a week and a half or two, start doing something about it already. If you enjoy these episodes and useful info on medicine, healthcare, and longevity, I have a free Telegram channel where I share this content. I'll leave the link to my Telegram channel below this video. Yesterday I operated on a female patient with a very large abdomen. She had been in this condition for about 1.5 to 2 months before surgery. There was a question of oncology, but she was undergoing chemotherapy and she had time to somehow adjust her diet and improve her nutrition. No, the first question she asked me when the surgery is tomorrow, do you know what it is? And can I eat strawberries right after the surgery? So she's not asking how much time she'll spend in the intensive care unit, but when she can eat. That's why excess weight is a big problem for us surgeons. First of all, it's immediately a problem with hormones. Second, it's systemic inflammation. Third, just physically, even if the surgery is laparoscopic, it's harder to place the port. And fat isn't just under the skin. The internal organs are also surrounded by fat, and the surgery itself takes longer. So to reach the kidney or the bladder, you spend a lot of time. This actually increases the time spent during the procedure, which raises the risk of necrotic thrombus. A question for the audience? These surgeries are quicker and wounds heal better. Conversely, being too skinny or dystrophic is also harmful. Just skin and bones is unhealthy. You just need to be normal. Strive for a normal physiological standard, the surgical area. Why is shaving a big deal? Many people arrive unshaven. That's true for private clinics, but when you're rarely admitted, they operate the same day. Usually they operate, well, most often the next day or in 2 days. They check the tests. If something's missing, they do additional tests. And with shaving, you know what the problem is? First of all, they shave incorrectly. For example, I operated on a friend. I told Gino to shave his chest, but he only shaved a small area around the nipples. It was hilarious. He's a hairy Armenian with just 2 shaved spots right on his nipples. So besides the fact that you are shaving wrong, there's also the issue of infection. If you shave 2 days before surgery, hair may not regrow, but there's time for a pustular infection to develop, causing the surgery to be postponed. You can't operate if a pustular rash appears. That's why patients shave the day before the surgery. And actually, it's best to shave with a trimmer because using a trimmer won't cause that pustular rash. It shaves very close to the skin, nearly to the base. Bodybuilders, for example, they shave with a trimmer before competitions and everything is fine. So it's better to shave with a trimmer. But if you use a razor blade, make sure to do it in aseptic conditions. Treat the area with chlorhexidine so you don't get a pustular rash afterward. Therefore, your surgery won't be delayed. 5th, periods. Patients often come in asking for surgery the next day, so we change all our plans. During morning rounds, she just says her period started. And you know, yes, you can't operate during menstruation. You can't because the risks related to blood rheology increase. A woman's blood coagulation system changes slightly. And that's why during menstruation, when the bleeding starts, we don't operate. We wait until it's completely finished. And then they start. So if the patient is a woman or you are female, and you know that, for example, you have surgery tomorrow or the day after, if you need to be admitted today, but your period starts tomorrow, don't get admitted. Call the surgeon and explain your period starts tomorrow and plan according to your cycle. You'll likely be admitted under a quota, but the spot may be wasted since you'll probably be discharged soon after. So it's a lot of hassle. You'll have to be admitted again. Your test might be expired. So you definitely need to check the date of your cycle and coordinate it with your surgeon. You know, the most common cause of death in surgery, the most common one, do you know what it is? You don't? It's a critical error. No, that's actually extremely rare. Thromboembolism, that's in the post-operative period because the patient is lying down, not moving, immobilized, and the body is set up for blood clotting. Especially if a lot of blood was lost during the surgery, the body tries to stop the bleeding and it clots the blood. especially if you smoke or if you are taking hormonal medications. If you don't move after the surgery, if you have varicose veins in your legs, and if you don't drink enough fluids, this raises your risk of blood clots. Lying down lets blood pool in your legs, increasing clotting. A large clot like this forms, and sometimes it breaks off. Usually they can stay in place, but sometimes there is a condition called flotation when the clot is loose and can break off, and this can kill a person. That's why, in order to prevent these clots, we always perform preoperative procedures. Ultrasound Doppler, that is ultrasound of the lower limbs, and that's why the list of tests you need to undergo almost always includes an ultrasound Doppler of the lower limbs. How can this be avoided? It's easy to avoid. There's a part handled by the surgeon. Before the operation, he injects you with blood-thinning medications like Clexane or Fraxiparine. He gives you these injections. This is done to make your blood thinner so that a blood clot doesn't form. But the best prevention, the best one that no one has come up with anything better than, is elastic bandaging of the legs. But even better is compression stockings. Bandages are worse, they're less convenient, they loosen up. If they wrap your leg with a bandage before surgery, by the time you're moved from the operating room, the bandages loosen. And the compression is uneven because there are areas where basically it just doesn't work. It's better to go and buy good compression garments, tell them you're not post-surgery, they'll help you choose the right level of compression, and everything will be okay. How do they work? Here's a limb with veins. The deeper veins are the dangerous ones, not the surface ones. When you squeeze your leg tightly with these stockings, what happens to the vein? Compressed, meaning it's empty, not open because you squeezed it. Accordingly, there's no blood there. And that's why it greatly reduces the risk of blood clot forming. And we, for example, myself and all my students, we don't recommend removing it even when the surgery is over. We allow it to be removed only when the person is already actively walking, because blood leaves the legs well when the muscles push it out of the veins. When you're no longer lying down, when you're already active, that's why we first get you moving, then the person walks, and sometimes we even say to wear it for another day or two, just let it be. This is a very important point. Now, about the bandages, there is this, annoying thing that I see with many surgeons, even they use bandages. First of all, they let the patient do it. They don't even check how the patient put it on, whether the compression garment fits. He bought it at the pharmacy. It's loose. It doesn't work. It's either too short or just knee length. That means the stocking should be high, up to the groin. That's the first thing. Second, it should be tight and properly fitted. Third, if you've never worn it before and you don't know how, that's also a factor. Special socks like these are put on the tip of the foot, making the foot more slippery and allowing you to easily put on good post-operative compression stockings. Grandma and grandpa might not even be able to put them on alone. It's that hard. And another very important point. Remember this rule. Under no circumstances should you put them on if you have already stood up. If you got up and walked around, which often happens after surgery, or if you didn't sleep and spent the whole night wandering, walking around, went to the shower, to the bathroom, went out for a smoke, breaking the routine, that's it. The effectiveness is much lower in that case. Lie down, and if you've been walking, elevate your legs for 30-40 minutes. Wait until the blood drains and veins are empty. That's standard practice. And only then, while still lying down, do we put all this on the legs. And one more thing. Everyone knows this, but still people sometimes come after eating or drinking. You shouldn't do that. Why not? Many people don't know why strict doctors don't let you eat or drink, but you must stop eating in the evening. If your surgery is in the morning, then you don't eat anything starting from the evening. So you can have lunch, but in the evening you can't have anything anymore. You can have water in unlimited amounts, but only until the morning. In the morning, when you wake up, you don't drink water anymore. What do you think? Why can't you eat? I remember I was told it's because maybe a person could choke. Yes, that's right. It's possible. There could be regurgitation of vomit. And since all those mechanisms that normally keep you from inhaling are, yes, that's right. A person under anesthesia doesn't cough because everything is relaxed and they feel nothing. All those protective reflexes, when everything closes up right away and doesn't let anything get in, if something goes down the wrong way, you'll start coughing right away and for a long time. That won't happen under anesthesia. You'll just take a deep breath with your vomit and burn your lungs. And that's a very high risk of fatal outcomes. Have you ever seen something like that? It's not a rare thing, it's actually quite common when a patient broke the rules and didn't say anything. Patients often lie. As Dr. House used to say, everybody lies, and patients often lie. They claim they had a gastroscopy, received treatment, and everything is fine, that they have a certain blood type, that they have no allergies to anything. They haven't eaten or drunk anything in the morning, or sometimes they say they had water with medicine, but how much? Just a little water, but during the operation they insert a tube and it drains out. So very often patients lie just to get to the operating table and they don't realize their risks. The same goes for periods. When they find out, they start lying. So never harm your doctor. Situations vary and complications can happen even if the doctor did nothing wrong. Sometimes the patient just didn't listen and removed their own catheter. For example, with suppositories, I had a patient who inserted them with the foil still on and kept waiting for them to dissolve. They came out and he put them back in. He was given suppositories and thought he should insert them with the foil still on. And the foil is square, so he cut it, which makes sense. They were quite convenient and even, so he would insert them in the trimmed foil like that all weekend, trying to dissolve them. But that's why sometimes you need to say things out loud that seem ordinary and obvious to you. But the patient, well, he never has in his life. I've had patients who don't know what a suppository is, don't know what an erection is, and many other things. So, if you've had any interesting cases related to treatment, doctors, or misunderstandings, jump into the comments and write about them. Give yourself a good mood. I'll check them out and read them too. I love these stories. I shared mine, so share yours in the comments. Another key rule is contact. It often happens that patients call after surgery and say, "I'm so-and-so, I'm a relative," or "I found your number somewhere." We never mind giving you useful, necessary information or reassuring you. But there is the law, and the law and our humanity don't quite align in this regard. And there is medical confidentiality. There is. If the patient didn't say that there is, for example, Uncle Vasya, who will call after the surgery and ask, "How am I?" We can't say, "You're fine," or "You're not well," even if everything went perfectly, because there is medical confidentiality. And when you are admitted to the hospital, there is always a consent form where you have to specify who we can talk to. So you have to write down who this representative is and their phone number. So be sure to give the doctor a contact person who can be reached and who can be given information about you, and write it down in the consent form. There's this thing that happens after surgery. Many relatives, for some reason, think they call and say, "We haven't been able to reach them since yesterday. Yesterday there was surgery, that's all." I say, "Yes, there was, but after the surgery, she is in the intensive care unit." He says, "Is it bad? Is she dying?" "No, after surgery." To the intensive care unit, always. After a serious, major surgery, the patient goes to the intensive care unit to stay under observation for the first 24 hours. That's when the risk of all complications, including leakage, is highest. And that's why you need to warn your relatives so that you can be admitted to the hospital. Many people get admitted, plan to have surgery, then call later without telling anyone. Suddenly the person vanishes, no phone, nothing for an entire day. So if you have a scheduled or emergency surgery, let others know you'll be unavailable until the next day. Not because anything's wrong, but that's just how things are. Preparation. Before surgery, it's often necessary to cleanse your intestines, not for a colonoscopy, but because most surgeries require bowel cleansing. For several reasons, including preventing you from soiling yourself and the operating room during surgery. These cases do occur, sometimes even affecting the surgeons when it flies at them. What should you do? There are various preparation options, from simply not eating. The second option is to do a small microlax enema in the morning before surgery. Some people use larger enemas. There aren't really any special features here, but sometimes when you're being prepared for surgery, they tell you to drink 3 packets of this laxative. Usually they're dissolved. I just don't want to mention the brand name. Dissolve each packet in a liter, drink 3 1-gallon, and it passes right through you. And many people make one very big mistake. They believe drinking 3 1-gallon in the evening, imagine 3 1-gallon is just water. They're not dehydrated, but that's not how it works. This drink actually attracts more water to itself. So you're dehydrated and you're also losing electrolytes, and you're increasing all the risks of thromboembolic and electrolyte disorders. And that's why it's absolutely necessary if you're preparing for surgery in this way. After finishing the cleanse, you must drink mineral water. Well, I recommend about 0.7 liters of mineral water and then another 0.7 liters of regular water to restore your electrolyte balance. Many believe drinking lots of water solves everything, but during surgery, when we're operating, with an artificial reservoir, the kidneys are blocked for 1.5 to 2 hours while the person receives intravenous fluids. The intravenous is running, you open the ureters, and there's no urine at all, because he just compensated, just absorbed it all. The intravenous is running and absorbing into the tissues. Many people don't sleep before surgery, and that's kind of normal, and it doesn't necessarily mean it's a major surgery. When I had knee surgery, I couldn't sleep and worried a lot. That's why I still don't recommend being unrested. And I think that if you have trouble sleeping or you see that you can't fall asleep, ask your doctor for pre-medication. They'll give you an injection and you'll sleep. That's why this point is important. Also, don't try to run a marathon or visit the sauna at the last minute. So, if you're preparing for surgery, you should live in this semi-rest mode for 3 or 4 days. Make sure you get enough sleep, cut out alcohol a week before, and if you use any prohibited substances, I also recommend stopping those. By the way, we see all of this during the surgery. We see everything because there is a certain dose of medication that we have to administer to put a person to sleep, and they work for a certain amount of time. And for everyone who abuses some illegal substances, the dose of medication you have to administer to them sometimes increases several times right away. If you give these medications to a healthy person and wait for them to wake up, it takes a long time for them to recover from anesthesia. But they're used to it. They metabolize everything so quickly that not only does it affect them poorly and require large doses, but they also come out of this state very fast. That's why anesthesiologists dislike working with former drug users, as anesthesia is harder to administer to them. Many people think that you can take any medications before surgery. Naturally, reasonable people understand that there is a list of medications you can't take, but they think that it includes what? Only some blood thinners, for example, right? Actually, no. There is a list of medications. I actually prepared it separately that I would recommend remove them because they really affect blood rheology, affect the central nervous system, and can influence your blood pressure and the risk of bleeding. What should I stop 7 days before surgery? Omega-3, vitamin E, garlic capsules, ginseng, ginkgo biloba, curcumin, and ashwagandha. So we stop taking these 7 days earlier. Antidepressants and nootropics may interfere with anesthesia, causing overstimulation, tachycardia, high heart rate, or hypotension. Which of those apply? SSRIs, that's things like duloxetine, primoxetine, and so on. These are serotonin reuptake inhibitors, tritico, modafinil, peracetam, phenibut, phenotropil. We remove all of these and don't recommend them. If prescribed by a doctor, consult with them since these are prescription medications. Tell me, I have surgery in a week, what should I do? We do not recommend diuretics as they can cause electrolyte imbalances. For example, many women like to use diuretics because they think it makes them look slimmer. If you are taking metformin like CO4 or something similar, you must stop taking it 2 days before because the risk increases. The risk of lactic acidosis increases. And if you are scheduled, for example, for some kind of surgery or procedure where a computed tomography scan with angiography is planned, that is, contrast will be injected. I recommend stopping iodine supplements 7 days in advance. This is the list of things you shouldn't do or take. And there are probably 2 more important points left. Very often you think that we won't take you to the operating table only if you have a high fever, like 39.5 degrees Celsius or pneumonia. No! If you feel something in your nose, each of us can feel when we're about to get sick tomorrow. If you have a scratchy throat, a temperature of 37.1 Ders or nasal symptoms, let your doctor know. You shouldn't have surgery, it's better to wait. Here too, patients often lie, and when you start to get to the truth, you can see it in their temperature and how they're feeling. They start hiding it, they don't want to cancel the operation. We collected the tests. I understand I'll have to be discharged and may spend 2 to 3 weeks taking tests. But under no circumstances should you have surgery if all this is happening to you.
You seem like you might get sick tomorrow, so you shouldn't have surgery before then.
We
listed all the points and explained why that's not possible.
Because you'll get sick, you'll have anesthesia with intubation after the surgery, for example. You won't be able to breathe deeply, you'll be lying down, and as a result, you'll get pneumonia. For example, I understand this surgery is a big stress, and your immune system gets even weaker. And as a result, what kind of purulent abscesses will you have in your body? Because otherwise you just had a pus pocket on your nail, for example, but now it has spread throughout your body. You have a focus in your kidney and another one here, the body. You're under extreme stress. Basically, when you're in surgery, you actually experience all these painful sensations and everything else in your body. Stress hormones even increase, so you shouldn't think of surgery as if the body just shuts down. It's so simple and easy, but actually quite serious. Well, it's a stressful situation, that's for sure. And of course, you shouldn't think that I just want to get it over with tomorrow to have surgery as soon as possible, because the consequences that will follow if you make a mistake will stay with you for your whole life. Perhaps in a purulent focus, probably the last thing I would like to talk about is a purulent focus, which a doctor must not fail to mention. Sometimes, for example, your gum hurts, sometimes your tooth hurts, but you came to have surgery on your leg and you think, what's the big deal? You might think, I just have a little abscess there. I'll get discharged soon. Absolutely not, absolutely not. There are very high risks of post-operative infections. Therefore, if there is any kind of focus like an infected nail or a painful purulent wound on the buttock, no matter if it's laparoscopic surgery, always inform your doctor and seek treatment before any surgery. Only when the purulent focus is treated. There are many stories. There are all sorts of rare conditions and complications that we've encountered. For example, here's an interesting one. During intubation anesthesia, a person's tooth with a gold crown broke off and flew into the lungs, and then it was retrieved. I've seen similar things in my practice. Anything can happen, so you must prepare for every operation in your own way. For example, if we're doing urethroplasty, the urethra, where there's a stricture that needs to be restored, sometimes surgeons need to replace that narrowed area, and they replace it with a buccal flap. A buccal flap is the inner side of the cheek, or sometimes they take the mucosa from our lips. It can only be taken if your mouth is infection-free and all issues are sanitized. First, treat your cavities and ensure your teeth are healthy before having the procedure. Preparation will also involve sanitation. So it's different everywhere. Besides these general things, which are very important, I think you should remember them, write them down, or save this video. There are also individual things. So treat the surgeon with respect and ask, what do you need to do to prepare in order to help him do his job well? I hope you enjoyed this episode, so please like and stay tuned for new ones.